Hey everyone, Puneet here. Welcome to episode 2 of the North of Patient podcast, Conversations on Health Beyond Care. Today's guest is Benjamin Heywood. Ben is a self-described mentor, investor, and tech geek who is currently general partner of the deep tech and digital health-focused venture fund, SkyRiver Ventures. Notably, Ben is the co-founder of PatientsLikeMe, one of the world's first and largest integrated online patient communities with over 800,000 members worldwide. Ben and his brother Jamie co-founded the company in 2004 in response to their journey dealing with their brother's diagnosis of ALS. I met Ben through the Creative Destruction Lab, where we both mentor startups in the digital health space, and I was immediately struck by his story and the unique perspective he has on healthcare. In our conversation, we chat about what it was like to start and lead Patients Like Me in their 15-year journey, the power of sharing in the healing process, what he's learned about the secrets of success in healthcare innovation, and of course, what he sees in store for the future. But before we start, I wanted to share a quick note about what happened the day I published the first episode of this podcast. In fact, I actually hit the publish button on the episode while I was in hospital with my younger son, who just had an allergic reaction. Everything turned out fine, fortunately, but I can't help but point out the irony of launching a podcast about reimagining healthcare while smack in the middle of a system that at that moment was doing its job brilliantly. The wait times were short, the staff, front desk, nursing, physician assistant, pediatrician were all super friendly and caring, and the plan was very well communicated. I'm well aware of the fact that the stars aligned in our favor that day, but I just wanted to highlight the learning lesson that we do have something to lose if we don't recognize that parts of our system at times work remarkably well. I also wanted to take this opportunity to thank the team at SickKids Hospital in Toronto for their care that day. You guys were awesome. Anyhow, enough from me. Let's get to the conversation with Ben Heywood. Ben, welcome to the show. I'm so excited to have you here.
Thank you for having me. I'm looking forward to the conversation.
Awesome. So, first place to start, I think the most obvious question we have here is, what is Patients Like Me and how did it get started?
Yeah, so Patients Like Me was a very early social network. We actually founded the company in 2004, the same year Facebook was founded. And the goal of Patients Like Me was to enable patients with chronic illnesses, serious sort of significant chronic illnesses, to share their treatments, their outcomes, their symptoms in an open environment and enables crowdsourcing of medical evidence. For the patients, they got very detailed information, not just stories, not just tips and tricks, which they did get, but they could find out, like, if I'm an MS patient and I'm experiencing this symptom, what are all the patients with MS, with that symptom, what are they utilizing for therapies or interventions? And they could really drill deep, even down to like dosing and other things. That was for the patients. For us, what we were trying to do is really crowdsource a very large amount of information, phenotypic information about disease, because we felt that was really a necessary information, real world phenotypic data about patients with chronic illnesses to really deeply understand biology and the human body, and therefore ultimately begin to create an environment where we could really begin to repair the healthcare system, which I know we're going to talk about that today, but that was the fundamental pinnings of that.
Gotcha. And was there a personal experience, something that happened in your life that perhaps gave the motivation?
Yeah. So the original founding, unfortunately, I lost my brother to Lou Gehrig's disease, but when he was diagnosed thank you. When he was diagnosed in 1999, our family did a couple of things. My oldest brother started an institute doing hardcore in vivo drug discovery. He opened a mouse lab and started testing on the market drugs in very large scale preclinical testing. Just to give you a sense, I think in the first 10 years, they put 20,000 SOD1 mice through that lab. And then about 4 years later, we started Patients Like Me, originally in ALS. That was our first community, but we very quickly expanded to other communities and other diseases. And unfortunately, we lost my brother in 2006, but it's interesting. So much of my last 20 years of my life and my brother's, Jamie, who's with us, who co-founded Patients Like Me, was defined by that experience. And on some level, a lot of positives for our lives and other people came out of my brother's illness, unfortunately.
Yeah, and I think it's one of those things where people also think of the feeling of helplessness when that kind of a thing happens. You often feel like, what are we supposed to do? Our kind of fate and where things are supposed to happen from here is in the hands of a system or an external party that we can't control or understand. So I can appreciate that part of it must have also felt like there's an opportunity to influence and control what's happening here.
Yeah, no, definitely. We used to talk about, I think, particularly with an illness like ALS, and there are lots of them. ALS is one of the worst diagnoses I think you can get. But patients really we're seeking three things. I think when you get a diagnosis of that severity, it's they want answers. They want to know what they can do, and sometimes there are no answers. Fortunately for ALS, there's been some very incremental improvements over the last few years, and I do think there's a lot of incredible science being done in that space now. But they want answers, they want community, they want to understand that they're not alone, and they want meaning, right? So if they're going to go through this, they want the ability for their illness, their experience, their journey to contribute to a greater good. And those three themes are what patients like me enable in a sort of digital internet scaled way. And they're really powerful. I think what we saw in the community and the stories and the sharing and the ability of one patient's experience to help hundreds of others was just incredible. I mean, it was an incredible journey, and I feel blessed to have been part of that community that we built.
Yeah, hats off to you guys for doing that because sometimes some of the best ideas are ones where you're like, how's this not been done before? Because it's on one level so obvious, especially in terms of a good use case for the internet. And is it fair to say that Patients Like Me was the biggest such community that was developed?
I think there are, yes, I think it's, if not the biggest, one of the biggest. There are other online groups, right? On some level, Facebook is the biggest community of patients, right? And then there are other companies that are doing, and rode that Web 2.0 kind of wave that we were on that just did straight community where they were building bulletin boards, Web 2.0 fashion, companies like Inspire. There were a few that came and went since we started. I think the focus on data as a core sharing component of our communities made it unique, and it enabled a level of clinical research that we did, and which is how we monetized and made revenue with pharma possible. And I think that was unique, and certainly in that regard, we're the only one of that nature, and certainly the biggest.
Just to double click on that a little bit, did either you or Jamie have experience in building web applications, or what led you from going to, hey, there's a gap here, which is that what are other people with ALS doing? Is that the first
Uh,
question?
this is a sort of funny story. I mean, when you start a company that has some kind of brand that has some sort of strength to the brand, the origin stories get a little muddled. First of all, we co-founded the company with a third friend of ours from MIT, Jeff Cole, who is our technical co-founder and built all of the original website with our very early tech team, Chris Nakachea and Steve Hammond, who were front and back end engineers that came in, I think, employee 1 and 2. So no, we hadn't built that. But the irony about Patients Like Me as a community, the original idea was that we wanted to enable online reporting of progress tracking over time. And we wanted to enable the crowdsourcing of data and information. But the community part, the literal forums, was like a last minute add to the MVP, where I think Jeff was like, hey, maybe we should put a community in here and see what happens. And obviously that changed the trajectory, and we might have gotten there later anyways, but it wasn't designed initially in that capacity. It was designed as a sharing platform. So bringing people together, but not necessarily like a forum where people were discussing stuff. So no, we had not built one. To Jamie's credit, my brother, and Jeff worked with him at the Institute as well. They were very early in understanding the power of the internet to reach patients. So the Institute, which is a nonprofit research organization, did monthly calls with the patients, which is not technologically novel, but is actually novel, right? Where you're bringing patients into the research, but more cutting edge. In 2000 or so, or 2001, they were live streaming the lab results to the web. So they had Kaplan-Meier curves, which is it's a death curve framework. I think it's for everyone, but certainly in mouse studies, those were being live streamed. Now the drug was blinded but it was a way to engage. And it's hard to remember how hard the idea of live streaming anything to the web in 2000, let alone a fully digital lab and digital system doing it. In that sense, Jamie was really ahead of his time and pushing the envelope of what was possible.
Do you guys come from an entrepreneurial family? So is the idea of starting things something in your DNA?
Not Not really. So we have interesting parents, wonderful parents, amazing parents. But my mom is a farmer's daughter from South Dakota. She grew up on a dairy farm, and it's still in the family. My cousin owns it, and his son is taking it over. But she got a full ride scholarship to Radcliffe, which is now part of Harvard. And then my dad was getting his PhD at MIT, and that's where they met. My dad is the leading expert on internal combustion engines, and he ran the automotive lab at MIT for 50 plus years. My dad's a very theoretical engineer, and I actually think farmers are the ultimate practical engineers. They just get stuff done. They build it. That if something's broken, they fix it.
Yeah.
So that background combined really made us, I think, engineers at heart and builders. My brother who passed was a custom builder, a home builder, but not entrepreneurial at all. We had no business. My mom did social work on the side, and my dad was a professor. He started a company, I think, at age 70, but that was after we had started and ran Patients Like Me. We somehow got entrepreneurial spirit. I think if I reflect on it, I think it comes from having a very stable home where the worst failure was I could go back and be there and be at my parents' house. The fear of failure, that I had so much support, there was very little fear of failure. And that's, I think that's an important entrepreneurial trait is not being afraid to fail.
That isn't the first time that I've heard people coming from farmer's family or agricultural background tend to have this sense of problem solving, resourcefulness, obviously hardworking attitude. And I think all those things really contribute to the sort of personality and aptitude you need to have in order to take on big problems, right?
Absolutely.
Was there any point at which people were questioning what you were doing and said, this is silly, there's no point in doing this?
Yeah. So when we first started, we would show the mock-ups and what we were planning on doing to ALS clinicians or physicians. And literally they would say, I don't think that's legal. I think you can't share data like that. And I'm like, well, people can do whatever they want with their own information. So the answer was they thought we were crazy. And again, we live in a sharing environment now, right? Like the whole internet is built on social frameworks and sharing. In 2004, that was not the case. Picture sharing sites were just novel. Twitter was still 3 years away. Instagram was 10 years away. The iPhone was 3 years away. So the idea of sharing was quite novel, and sharing sensitive information like personal health information was really, I think, breaking a lot of stigmas. We don't talk about healthcare stuff because we're told not to talk about healthcare stuff. But why don't we talk about healthcare stuff? Everyone we know is dealing with something, whether it's them directly or a family member. And particularly on the mental health side, I've seen this through COVID. It's just universal. There's no one who's not touched by that. And somehow we're still afraid to talk about it. I think that was on some level the most powerful thing we did. We helped redefine what it meant to, one, for patients to own their info, and two, like the idea that sharing is potentially part of a healing framework that's very important. And you can do it technologically and at scale. And it's not just neighbors over a fence.
I'm really catching on to the statement you said there, which is they thought we were crazy.
Yeah.
Which I think speaks volumes to the idea of anyone who's questioning the legacy methodology with which an institution runs is always going to be up against that statement, which is, this doesn't make sense. What do you mean people can have access to their diagnostic results directly? That's absolutely insane. Or what do you mean people might want to talk to a bot first to be able to work through their symptoms? That doesn't make sense at all. I think a lot of that is happening right now, right? And I think so many people find themselves with this question of, if we think differently about how we approach healthcare, can we actually uncover value? And at the end of the day, it all comes down to the patient's interests, right?
Yeah, no, absolutely. And I have a lot of conversations with friends who are physicians, and obviously it's a very challenging time to be a physician. A lot of what they wanted to do when they went into the field is hard to do, and the system makes it hard for them to be healers. There's emerging fields that have been around forever, like functional medicine, where it's questionable some of the stuff that's being done, but at the same time, the biggest thing they're doing is coming and listening and talking and spending time with patients. And my physician friends tend to poo-poo that or don't like that, but that's what they're not the listening part, but the functional medicine part. But that's what they're missing. They're missing the ability to be a healer, to listen and engage and digest and work with patients. And so I do think there's just a lot of models that we don't allow or enable right now that that could come to fruition. That's where I do get excited and hopeful, like about what's possible coming. And I can talk a little bit about some of the stuff we did at the end of Patients Like Me that relates to, I think, some interesting models. But I just think there's a lot of stuff that we need to figure out, and I think we will figure out, but it's challenging and to the current apparatus.
Yeah. Listening unencumbered by bureaucracy, where
Yeah.
it's not attached to the completion of some kind of form or some medical
Yeah.
legal prerequisite, and
Yeah.
really just understanding that this person's going through something. And again,
Yeah.
you're absolutely right. I'm a practicing family doc. Going through medical school, we all shared that original idea of, hey, we're here to do a good thing. And then it doesn't take very long for you to realize that you truly feel like a cog in a machine where
Yeah.
you're executing a function as opposed
Yeah.
to being there for people. And I think
Yep.
so many people talk about administrative elements of burnout and doctors having
Yeah.
to do things they don't want to do. Absolutely true. But I think it's the distancing of the clinician from the
Yeah.
actual act of healing, which
Yep.
truly leads to people feeling like they're paper pushers and administrators as opposed to feeling empowered to be there to help people, right?
No, that's really well said. And that's why I actually talking about healers, because one, it spreads who can do that beyond just clinicians and physicians. And two, it is, I feel like, what most physicians went into the field to do. And it's a powerful thing. I'm getting chills just talking about it. It's just thinking about the idea of healing. It's really a meaningful thing. And that's some of this, that soul of healthcare. It's very hard to find in the current US healthcare system.
Yeah. And I feel as an overall healthcare system, particularly kind of Western medicine, allopathic medicine, is beginning to slowly open its research eyes towards a lot of things more centered around everything that's called alternative therapies is
Yeah.
now being double clicked on. And they're beginning to look at, oh, there's some kind of benefit we don't understand around people walking for 30 minutes in nature. Sure, we might not be able to explain everything purely in the biochemical sense, and maybe we will, but
Yeah.
there's something there that provides value to people that's a little bit beyond placebo, right? And
Yep.
I think we're beginning to understand that, and that gives me some hope and optimism that we'll converge at something that understands people as a whole unit.
Yeah, no, absolutely. And I'd say that I mentioned it, but what we did at the end, what we were doing at the end of my time at Patients Like Me is we were working with a brilliant Chinese geneticist and scientist named Dr. Jun Wang. And his first company was BGI, which is the largest gene sequencing company in the world. And his next one was iCarbonex, who we were partnered with and working with Patients Like Me. And what I loved about him is, yeah, exactly that. Look, what we do in Eastern medicine, half of it's probably crap, but half of it's probably really deeply meaningful, but we don't measure it and understand it well. And what you guys do is over measure it and over understand stuff to the point that it loses all of its soul. And I really like this idea that there's like the best of all these things. And your example is perfect in that sense of being in nature. And what does that do? I don't want to be flippant about depression, but no one who's trying to survive in the wild is depressed. They just don't. And so there is something connective of our body and mind to the earth and our environment that gets disconnected in our modern society. And I think this is where I do think we will be able to tease out those whether you can recreate it artificially or create systems and or environments where it happens as part of your everyday life. I don't know, but I think we will be able to understand more and more of the biochemical effects of that over time. And that's where I actually do get a little bit excited about what's possible in the future.
100%. In so many ways, I feel like the science of medicine is truly in its infancy. And we've relied so much and we've done so many positive things with the art of medicine. I feel like we're now beginning to build the tools that really allow us to deal with data, obviously at scale. And this probably begins to intersect with some of the themes and things you're thinking about
Yep.
now in
Yeah.
terms of deep tech. Just to wrap up that story around Patients Like Me, you left the organization formally, or are you still involved there?
No, I'm not involved. I left in 2019. It's a bit of a long story, but we were working with our partner in China and a very cool biotechnology company out of California and an Israeli AI team to really build what I talk about as a full stack digital state biology platform that would enable, I think, next generation application layers to happen Unfortunately, trade wars and anti-China sentiment got in the way of that. And there's a federal government thing called CFIUS, the Committee on Foreign Investment in the U.S., and they forced a breakup of that merger. So when Patients Like Me sold back, we sold it back to United Health Group on the R&D side, and then they ultimately spun it out as a new startup, venture-backed startup. That's when I left and started thinking about my next thing.
And how long ago was that? That would have been?
That was 2019, so it's been 5 years now.
Gotcha. And so what are you up to these days, Ben? Tell me a little bit about SkyRiver.
Yeah, it was an interesting journey. So I left in 2019. I had been at Patients Like Me from this founding, so 15 plus years, 11 of those sort of running it. It was a long, tiring run. We did a lot of good, and just an incredible experience. And the patients that we helped in the community, that how they came together was just incredible. But I needed a bit of a rest, so I had a grand plan to take to 2020 and travel a bunch with my wife. And I used to tell a joke which was, how do you make God laugh? And it's make a plan. And God laughed at my plan, and COVID happened. I was doing a lot of helping my kids with Zoom and being around the house. And there was a terrible time for the world on some level, but we got a chance to tight knit close, hang out with my family. And that was wonderful. But at that time, a friend of mine from childhood actually reached out to me, and he was leaving Samsung Ventures, where he had been for over a decade, and to start his own fund. And he was looking for a partner in crime. And so we joined forces and launched SkyRiver Ventures in 2021. SkyRiver Ventures is a deep early stage, so pre-seed, seed, deep tech and digital health venture fund. We want to find companies with hardcore fundamental intellectual property based in technology or science that we think can grow and be large global companies. And so we launched the fund in 2021, and we've made 8 investments to date out of Fund 1, and it's been really fun. I haven't sounded that pessimistic, but I'm still a little pessimistic about the U.S. healthcare system. But on the world's problems on deep tech, I'm much more optimistic.
Yeah, but maybe before we dive into that, I guess for the uninitiated on the VC world, and a lot of people in healthcare obviously aren't exposed to that. In 1 or 2 sentences, what is VC?
Yeah. So venture capital, you're investing in startup companies that obviously need money because they're not profitable yet. Generally, you're investing in companies that you think can be very large, high growth companies. It's not perfect, but we want most of our companies, we want to see a path to them being billion-dollar companies, hundreds of millions in revenue plus, or maybe even $1 billion. We're not looking for companies that have small visions. We want big visions. You're investing in the stage we're investing in is really just founders and an idea and some prototypes, maybe a product that's been tested by customers, but it's pretty early in the journey of a company, and it's high risk capital. So it's high risk, high reward. On a fund like ours that is early stage, you would expect half of the companies to not succeed. And then you want, out of the 25, 30 companies we invest in, you'd expect couple to be monster successes, and then the rest in the middle. And it's a portfolio construction that the math works out to being a nice risk reward for what you're doing. And there's lots of funds that do very focused stuff, like an AI fund or a healthcare fund or a digital health fund, or we're doing deep tech and digital health.
And what does deep tech mean?
So deep tech, it means a lot to a lot of different people, but for us, it means any hardcore fundamental engineering and science-driven technology that kind of drives the core of a company. So for us, that's obviously AI right now, robotics, big data, quantum computing, advanced materials. It's a very exciting space right now. So novel, we're really beginning to understand how to design and synthesize really novel materials using both AI and novel synthesis techniques. So in our portfolio, we have a super polymer that's lighter and stronger than steel. And we also have a green cement company that is taking a lot of carbon out of the creation of cement by using waste stream products as a starting point. So it's just a lot of exciting stuff. And for me, and I mentioned the optimism, I just think I was a lot more pessimistic about our chances of surviving climate change and other things before I started doing this. And now that I see all the entrepreneurs working on really hard problems in this space, I'm much more optimistic that maybe a bumpy road, but I don't think we're on a path to killing ourselves.
Necessity breeds ingenuity. At least historically, it's worked that way. And you're absolutely right. I think when bright minds get focused on real tangible problems, human beings do find a way forward, right? And
Yeah.
it's always reassuring to hear from people who are at the front lines of that, who are actually seeing it happening, because a lot of times people do get exposed to just the problem and perhaps not
Yeah.
the solutioning. Um,
Yeah.
so you're based in Boston, if I'm not mistaken,
Hmm.
and Boston's often seen as a major hub for all things happening in the advancement of healthcare. Being on the ground there and being in the VC community, what sort of interesting patterns are you seeing in terms of investment into digital health and healthcare in general?
A couple of, I think, major themes that sort of maybe I see them more because they're things that I think are interesting and can solve some challenges, right? So, one, there's a lot of companies that somehow have as a component sort of leveraging nurse practitioners and physician's assistants with a couple of clinicians to amplify and scale faster. So, sort of using obviously slightly more inexpensive, easier maybe to grow clinician types to solve some of just the straight up challenges around scale and the number of clinicians and burnout and all that stuff. I looked, there's a very interesting derm clinic here that's doing that. And they're using, I think, nurse practitioners and AI to do very, initial screening of skin lesions. So that's one area. I think obviously people still aging in place in home care. I think that's still a massive desire of lots of the healthcare system. It's hard. It's still hard, and I don't see a lot of stuff, but we have a robotics company in that space called Labrador Systems that has built a very cool assistive technology robot that can move around your apartment and move your laundry from the laundry room to the bedroom and your groceries from the front door. And then if your nurses set up a bunch of trays, it can hot swap trays for like medicine or food. And if they're successful, that'll be a first in class, really, in terms of assisted robot in the home. Really remarkable roboticists are running that business. So that's another area. Obviously, AI and big data, right? Particularly, I think the most success in terms of actually getting into the clinic are, I think, our imaging and technologies, whether it's reading pathology or scans and the early, all of them now are physician assist technologies because no one wants to jump in the deep end right away. But eventually I think those will be taking over. And I'm not sure why there aren't like two or three pathology read companies in the US, and other than the fact that it's a massive revenue stream for hospitals. So that's another area. I think there are some alternative financing frameworks, things like PACE that are taking on Medicare, Medicaid, PACE programs that are taking on risk for either large populations or high frequent flyer, expensive populations. And I think once you do that, then they're looking for innovative solutions to do anything, keep people out of the ER or whatever. So I think biotech is, in terms of therapies and CAR T and all that stuff that's happening on the biotech side, I think just massive stuff and very exciting. But that's an area that I don't directly invest in. But I think medicines are incredible right now. And the next decade, it's going to be incredible. What do you like on this space?
Yeah, I think in the short term, in like the near horizon, as you can imagine, so much focus is on liberating clinicians from having to do a lot of manual administrative work. To me, that's always
Yeah.
been the low hanging fruit. Let clinicians be clinicians, let nurses be nurses, let them work at the top of their license, if you will. So it makes a lot of sense to be able to extract those duties from clinical team. I think 100% being able to scale clinical expertise and share it amongst care teams is hugely important as well. So whether it's paramedics being able to identify certain pathologies like right at in people's homes and in acute situations and be able to be a little bit more autonomous, perhaps allow the hand of the hospital to reach further into the community
Yeah.
through that. I think those sorts of things can make a really big difference in people's lives. But I think the bigger thing that when I look into the horizon, I think there's a lot of really interesting things to happen in the space of allowing people to be drivers of a big part of their own preventative health in particular. Because you can think of
Yeah.
healthcare as the kind of stuff is really wrong, and you obviously need both technology and intervention to take place. And then there's the how do I avoid things from happening down the road and the true idea of preventative health. And I think a lot of that can really be done in partnership with patients to a much greater extent. That to me is a really exciting space because being able to actually prevent disease in a
Yeah.
meaningful way and allow people to live optimized lives is I think the mecca.
So the thing, it's interesting. One of the things you said in there that I think a lot about, and I don't have answers, but I think it's an interesting question. So you talked about the hand of the hospital coming into the home. Like hospitals are one of the many community institutions that were at the center of communities and historically. And the problem is, especially community hospitals, the economics don't seem to work. I'm not quite sure I understand why they don't work because it seems like they should be able to, but they aren't. They're not great. And less, we don't want to be bringing people to the hospital. We want to be trying to distribute care. And so this is like challenge of they have this infrastructure and this CapEx and this real estate around being a hospital, but that's probably not the right answer going forward. And yet losing them as a community institution is we're struggling with this in all aspects of our lives, that we are losing the institutions that made us geographically, locally a community. So I struggle because I don't want to say we don't need hospitals, because we need hospitals when we're really sick. We need hospitals to be thinking about this thing, but they also might not be the right model for caring for chronic ill or going back to healing or certainly preventative. I think they've shown that they're not great at that environment. And so it's an interesting dilemma for the system because it's been the center of the work, and I'm not sure it makes sense if that's the case.
Yeah. And I had a very interesting personal experience just a couple of days ago, around the time that I was first launching the first episode of this podcast. As I was launching it, I was quite literally in the emergency department with
Oh,
my youngest kid,
oh,
16-month-old. He'd had an allergic reaction to something, and we were seen in a very timely fashion. We were triaged. The front desk staff were super nice. The nursing staff were super caring. Everything was dealt with within 2 to 3 hours, and we were in a comfortable private space, really feeling like we were being listened to and heard. It was exceptional care. I'll give a shout out to the SickKids Hospital here in Toronto for doing that. I know they're already recognized for being a fantastic institution. And I know it doesn't always work out that way, and we were lucky with timing and so many other factors. It highlighted this point of not everything is broken.
no, yeah, when it works, it's magical. And then when you need it, this is where it's hard to be critical. They were magical, right? It's exactly what you wanted. And you could see what's possible. It's just yeah.
Yeah. It drove home the point that we actually do have something to lose as well. I know there's so much conversation, particularly in the innovation community, around disrupting healthcare and the need to start from scratch. And there's obviously merit to that. And that conversation is coming from a certain perspective, but we do certainly have something to lose. And I think we need to think about how we build on things that we're doing exceptionally well and really rethink value in kind of other areas. But this kind of reminded me of a conversation we had. I remember we were having dinner last year, and you'd mentioned your experience receiving healthcare in Boston. And it was an eye opener for me because, again, being here in Canada, and we think particularly about places in the States that are centers of exceptional healthcare, and Boston comes to mind. And I think your articulation of some of the challenges in accessing healthcare, and even in a place that's globally considered to be a hub for healthcare innovation, was really drove home that point. Can you talk a little bit about what it's like getting healthcare there?
Yeah, a few things. I'm always somewhat amazed that anyone's satisfied with the system in the US and that they're worried about changing the economics or the payers, or when Americans like to crap on the NHS and Canadian health system, even there's a lot to like you left and didn't think about it, Bill. So a couple things. One, quite frankly, sadly, when I need a specialist, I have to go to my doctor friends and who do you know? And then mostly I'm getting usually a good name and an entree into that referral. But I'm also sometimes just getting a classmate of theirs that may or may not be a physician that is of merit. Wait times, right? Everyone talks about when we like to make fun of the Canadian healthcare system, they talk about wait times, but I'm waiting on my first prostate exam, and my appointment is 8 months out. That is, I'm 3 years behind when I should have done it. So another 8 months isn't going to kill me, but
so the wait time wasn't a concept exclusive to the Canadian healthcare system.
Yeah, exactly. Yeah. And my wife was trying to get in for something she had, and to a specialist. It took 6 months. Now, that being said, like you, we have an amazing children's hospital. My daughter just had a surgery, and I probably had one of the best surgeons in the world, and, teen girl knees, right? And it's nice knowing I didn't have to do too much work to filter that out and find out. Whereas I had a knee surgery 25 years ago in Fremont, California, and I'm pretty sure it was a chop shop, and I probably should have spent more time thinking about the physician. But again, to the point you were just making, like when you need something, like my brother's old physicians are two very well-known ALS physicians, Dr. Bob Brown, who's a geneticist at UMass, and then Merit Sikovich, who's now the head of neuro. If you're dealing with ALS diagnosis, and I get a lot of those patients coming through me in various ways, like you want to talk to Merit. She runs neuro at MGH, and she's one of our leading experts on ALS. Nice to be able to access her easily, right? But the thing that's harder to think about when you're thinking about the healthcare system and investing and like Massachusetts, even though I'm now critiquing some of the challenges, it's the best of the best in the US, right? And if you're in a rural community, or you're in a place where the actual community hospital shut down because it just didn't work economically, like your access to care is really challenged. I forget whose quote it is. The future is now. It's just not evenly distributed, but we forget how unevenly distributed the quality of care is, and how important and how drastic that can be in certain medical outcomes. When you go from the 0.1% to the 1% to the 10% to the below average, your literal outcomes can fall off the charts in that journey. And that's what's a little hard to think about, because I'm surrounded by technologists and innovators and great research institutions and hospitals and great clinicians. The reality is half of the clinicians in the country are below average. That's just, and
statistical reality.
Yeah, statistical reality. Now, hopefully you're raising the average over time, so that's less and less meaningful, but which is why, again, technology can do that, right? AI assistant stuff. And again, I'm not Pollyannish about how it's going to magically fix everything, but it can improve a lot of things.
Yeah, I think that leveling of the playing field is a positive thing to think about, which is that regardless of where you are, you still have this diagnostic machine available to you at your fingertips that can spit out the same diagnostic accuracy and precision that you would get if you were at MGH, for example, right?
Yep. It's important that we don't bring that down to everyone. We bring everyone up to that.
Exactly. And that touches on another important point, which is cost. And I remember you mentioning, even without having to deal with specific complications or surgeries or interventions, just at baseline, you're shelling out tens of thousands of dollars just to be able to be in the loop to get care.
Yeah. I'm buying family plans on the open market, and I basically spend the equivalent of a full-time $20 an hour job on healthcare. $20 an hour is that's a pretty good job in the US. And that doesn't really cover anything. It obviously covers catastrophic stuff. God forbid that ever needed. But in terms of like everyday care, it's just money you're burning. And I would just prefer that we did a better job societally bringing that money in and utilizing it to improve the broader outcomes of everyone better than we do. The numbers on US dollars spent versus outcomes, the trade-off is terrible. And yet, to the point when you need the best of the best, this is where people come. And I struggle with I often struggle with how to reconcile those two realities, that our dollar per outcome is some of the worst in the industrialized world. But when people want to get really sick, they come here and find the person they want to be here. And those are two realities that are hard to reconcile as you're thinking about improving the system.
Yeah. And elevating the bar, the lower end of the bar, I think is the important part. And the question becomes, is that where the interest of innovation lies? Is it in elevating the bar, or really taking the upper end of that range to an extraordinarily different place? And obviously both need to shift and move, but I think it's the driving factors of the healthcare system and where people can find opportunity. Basically, where is the money for people who are trying to innovate? And it may or may not necessarily be in one bucket or the other.
And then I do think it's interesting. I think that's a well-described thing. I think we do invest in taking the best of the best up higher. And that probably drives a lot of the cost. I have an old Patients Like Me colleague who's taking the best of the digital health solutions and putting them into a bucket and taking them to community underserved health centers and saying, hey, you don't really have the resources to go out and figure out which of these work, but I've now curated a set that have really good outcomes. And I'm going to help you to deploy them into your population culturally and community-based sensitive way so that they can begin to get some of these novel solutions that can really make a difference. And that's a company and it's a mission and a passion for him. But I think you do see that happening even in the sort of startup space of people trying to bring novel tech to broader audiences. And I think that will pay dividends for the system.
One of the other questions I think about is the evolution of the traditional healthcare system in the context of deep tech and new technologies. And being in Boston and being around so many large institutions that represent the upper echelon of traditional healthcare, do you get the sense that they're going to be able to go along for the ride with where technology is going? Or do you have concern that they may not necessarily be able to ride that wave and really what's happening is a bypassing?
It's a great question. I don't know if I care about the answer to that because either solutions are going to come up that add value and they'll figure out how to incorporate them into their models, or there's solutions that come up and out value and they'll outcompete them. I do see MGH is building $1 billion new inpatient hospital bed with building. And I'm like, is that a good utilization of, I don't want to say it's not, but it's nice. We're going to get state of the art. And if I need a patient bed, it's probably where I'd want to be. But we've talked about this and I don't know if you're going to get this later, but I think we are still, there's still a set of technologies and information that we need to deploy so that there's a data and technology layer on which novel new ways of helping people heal and prevent illness can happen. And I think those layers are coming in, obviously compute, AI that we're seeing everywhere in every industry. But in healthcare, this assumption is, we have all this amazing data in these EHRs. And then when we have that compute and data, it'll just magically solve everything, and genetics as well. And the reality is genetics is somewhere between 5 and 15% of the problem. So that's an important signal, but not the signal. And quite frankly, I think 95% of the data in the EHRs will not be relevant in the future of healthcare. Now, whether that's 10 years or 20 years from now, that we're not building the Star Trek tricorder on EHR data that we have in the system today. It's going to be on novel biology and novel sensors that are being built right now.
Yeah. As you might know, I've worked in the EMR industry for 10 years, and I helped build actually one of Canada's first cloud-based health record systems. And having been somebody who is so close to the information on other platforms and the way information is recorded, I would have to say I agree with you. I think we overvalue the data in EHRs, or we have at least historically. We're realizing that now, that the secret sauce to building high capacity personalized healthcare does not rely as heavily on EHR data as we perhaps once thought.
Yeah.
Doesn't mean there aren't meaningful data points we can get from there, but I think we'll all be surprised at how little of that we need in comparison to other sources of data that are much more reflective around what's happening inside people's bodies and being able to actually engineer, if you will, the biochemistry of the human body.
And I have firsthand experience about that because we were running a massive at the end of with iCarbonX and Patients Like Me in sort of the 2016 to 19 timeframe. We were building a massive precision medicine program where we had a couple thousand patients enrolled, multi-time point blood draws, 1,000+ proteins, full genome, RNAi data, antibody data from this technology called HealthTel. And we were running this. So I just think that, and when we ran that, just the amount of signal that having a patient's EHR data added to what we could do without it was almost negligent. Now, imaging is a slightly different. When I talk about EMR data, I'm talking about sort of lab and other data that's very underwhelming in terms of quality. But imaging is much more mechanical, and we're already seeing tremendous strides with AI and imaging, and that data is probably much more important. for the tasks at hand. We're going to have millions of data points. You talked about biology, also sensor data points, both ambient and then chosen sensors. And I just think the reads off that are going to be super powerful. And all the work that my brother and our family and patients like me, we've done, the thing we talk a lot about is the way technology improves things is rapid iterations, right? And in healthcare, you can't iterate quickly because you don't know whether something works. If it's a drug, you got to test it. And if it's an intervention, you got to wait. And so the variable that you really want to optimize, and no one ever talks about this in all of healthcare, is the time to know whether an intervention works. The shorter the time to know if an intervention works, the faster you can iterate and figure out what works for you or broadly for others. I just think no one talks about it that way, but that's a lot of the work we were doing. And biology and sensors will enable that, right? We'll be able to, you take a new drug, instead of waiting to see if it, is working for you, you'll be able to see it directionally instantly. And that's where I get excited. But we have to build this massive data and understanding. So we have a map of biology. We're still, you talked about moving the art to the science of medicine. Biology is still in its infancy on some level, despite all the incredible stuff happening. It's very early in that revolution. And then once that's there, then the entrepreneurs and the venture capital and the foundations and the institutions like MGH can come in and begin to do, I think, much more novel and interesting ways of engaging and helping people.
From your vantage point as somebody who's built this globally successful patient community and digital health platform, as somebody who's spending a lot of time focusing on the next digital health, big deep tech companies, can you describe what a great outcome might look like in healthcare, let's say 3 to 5 years down the road? I like to say in the...
Wait, how long down the road?
3 to 5 years. So let's say in the post-AI stabilization world, where we've blanketed some degree of AI capability in almost everything we do, we've learned how to interact with it. What does good look like?
So
and there's no right and wrong answer.
This is where I get pessimistic. So I'm going to steal a line from Charlie Baker, who was the governor of Massachusetts, and he ran a healthcare system. And I think one of us, I might even asked him 15 years ago, what do you think healthcare is going to look like in the next 5 to 10 years? And he said, probably what it looked like in the last 5 to 10 years. That's just not enough of a time frame for me to think it's going to be. So I think in 3 to 5 years, I think we'll see more and more AI coming in, AI assistant, over the shoulder kind of stuff. That'll enable systems, institutions, clinicians to get comfortable with it. So I think we'll see some of that. Not sure that's going to be that traumatic, right? Sadly, I think the burnout problem, I have many friends who are it's hard. It's hard to be a physician right now. And we need great physicians to overcome some of the institutional challenges we have. On that time frame, I don't think that much. Obviously, I think there'll be more and more drugs that are coming on market. I think that'll accelerate. I'm more in the 10, 15 year time frame, and I think there's a lot of stuff in that sort of what I would call medium term time frame, which I think is going to be super exciting.
Okay, but even beyond the prediction of what might actually happen, what could be a good outcome? So if you could park aside reality and say, this would be a really nice thing that technology might enable us to be able to do, what does that look like? And how does the human interplay with the technology in that world?
Right now, we all know we should eat better. Eat what Michael Pollan says, eat veggie, mostly vegetable, eat meat a little less, whatever. He's got a great haiku around that, which I just butchered. But we should not smoke. We should get out and move. A few other things that every clinician will tell anyone. And we intuitively know that when we wake up or we drink too much, we just don't feel that great. We know that. But I think more and more, if we can quantify how things affect us, you'll just have a better awareness of it. I'm not a massive quantified selfer. I don't believe it's a panacea, partially because a lot of the stuff we've been measuring, we still haven't figured out if it has meaning. But I do think being able to see the effects in real time, not months down the road or years down the road, of good and bad things you do to your body and your health, I think will enable people to just course correct ever so slightly and ever so more effectively. What does that look like? I don't know. I think that looks like 1,000 different things. It looks different for you than it does for me. It looks different for someone on the verge of being type 2 diabetic or someone who just got diagnosed with a significant illness. We used to get like, why hasn't the internet affected healthcare? And it's because they don't have a computable data framework that allows digital natives to innovate. And all the ones who have been trying for the last 15 years realize that the problem is that the data is not good. I think there'll be 1,000 flowers blooming when we have the infrastructure and the data layer that allows them to bloom. But right now, I'm excited for it, but I don't know what it'll look like.
That's a great image. The thousand flowers of healing potential and the opportunity for people with ideas and solutions to be able to hack away.
Yeah.
I think that's a great way to be able to picture things.
Yeah.
So, do you imagine patient care communities to be playing an important role in the healthcare in the not so distant future?
Yeah, I think peer models of healthcare have been around forever, right? You talk about Weight Watchers, about patients like me, the guy who did the Blue Zone work where they showed where the highest oxygen and centenarians lived. A lot of what was some of the core components of what made those communities live longer is that they had structural community engagement, whether it was groups of people that were put together at birth and kind of lived through their life as like a forum, or they were walking as part of their everyday life and infrastructure, or they had a little social component at the end of every night as built into the community or the family. Like all of those things are peer to peer frameworks. And then obviously, and Alcoholics Anonymous. It's just an immense. So I totally believe in the power of it. And the question is, how do you find where it can really lever up and make a difference? And then how do you connect those affinity groups, whatever the affinity is, whether it's a disease state or a local community?
As a last question from my end, what do you think healthcare providers and system leaders should be doing today in order to be able to prepare for tomorrow? Or what would you like them to be doing more of?
That's an interesting question. I think the thing I struggle with when I think about the physician and clinician community is we've built up over time these deep specialties, right? And then the primary care person is meant to be the coordinator of this football team of specialists. But primary care has been neutered of the ability to do that, right? Just with time and energy and focus. And then the specialists are so specialized that they don't have any holistic view, right? I have a friend who's a gerontologist, and the first thing she does is, de-escalate the pharmacy of all of her patients. She gets a new patient and she just starts taking drugs off. And when you're a specialist and you're going to see a new patient, you're not going to take some other specialist and other things drug off, even if it maybe doesn't make sense to be on both. It's just very hard. I think one of the fundamental challenges is the specialties came into existence for a reason, right? They've made incredible strides in their ability to care for very specific stuff. But it means we are less and less holistic view. And certainly as the primary care physician has not been enabled in that role. So I say that in the sense of, I don't know what the answer is, but I would say that a more functional medicine view, which again, to any of my clinician friends, me scratching a chalkboard with that word, I think is important. And I don't know how you bring that back, because the specialists are specialists for a reason. And the primary care people want to do the right thing, but they're not being enabled. I don't know. I wish I had answered. This is where I get a little bit more pessimistic.
Yeah, no, it's a tough one, and I think that in so many ways, the science and discovery of the human body and medicine dictated the way in which we practice.
Absolutely.
As we began to unlock the mysteries of the liver or the heart or whatever else, or the kidneys, then we began to practice on the basis of that knowledge, and the assumption that the thinking around that would be dependent on a human being who would have this deep of knowledge specific to that organ system. And I think
Yeah.
that made sense when thinking was the activity solely of human beings. I do feel like we're at this crossroads where early days still, but thinking is increasingly going to be something that's done better, or at least parts of it, by non human entities.
Yeah.
And I think that forces us to wrestle with the idea of how do the human elements of the healthcare system really interact with care delivery, when there's
Yeah.
just always going to be a better diagnostic thinker as long as you give it the right data.
Yeah.
And it might not be able to get certain types of data like physical exam findings and so forth, of which there's questionable utility over time as well. But it's that interplay that I think is going to be really interesting. And it's going to be the tension between those cultural infrastructure and the capability and the technology and what it actually needs or dictates.
So I think to your question about, I would just say the specialization, I would just be open to the remapping of that. Just to talk a little bit about stuff we're working on. My brother has a new company, Alden Scientific, which I'm a personal investor in. It's based on all his experience building preclinical work and the work we did at Patients Like Me. And they have this engine, this informatics engine for novel emerging biology frameworks that when they begin to map the important systems in the body, it becomes a multimodal thing that has nothing to do with organs and other things. And it becomes almost a new set of things that we should be focusing on to go after and treat that are less obvious. They're more systemic and the intersection, and that's all through AI and novel biology.
Ben, I truly appreciate the opportunity to have this conversation. This has been a fantastic chat. It's always great to chat with you, but I particularly appreciate you making time to do it in this forum. And I think people will have a lot of interesting things to take away from here.
Thank you. I appreciate it. It was a lot of fun. I am excited about where we're going. I'm very excited about where we're going. I just think it's going to take a lot of work to get there.